دلوقتي معانا دكتورة هدير عفيفي، أحد الشباب برضو الصاعد الواعد في دمنهور، وهتقدم كيس برزنتيشن. اتفضلي يا هدير.
ماشي، بسم الله الرحمن الرحيم. 48-year-old male patient referred to our hospital complaining of anorexia, nausea and vomiting with increased renal function test. Patient was hypertensive but not diabetic. History of splenectomy 10 years ago. Patient gave history of diuretic use for the previous 2 years for lower limb edema. Non-hepatic HCV positive antibodies confirmed multiple times, while PCR was positive first time with low viral load and excluded from the treatment with interferon. Then PCR repeated 3 times and was negative. Condition started 2 weeks before presentation by nausea, vomiting, and anorexia. Patient sought medical advice and received non-specific treatment without improvement. Routine investigation done and showed increased renal function tests. Serum creatinine was 6.2 milligram per deciliter. By examination, blood pressure 160/100. Chest was clear by auscultation. Abdomen mild ascites and mild bilateral lower limb edema. Investigation show increased serum creatinine to 8.2, urea 184, urine analysis albumin +3, C3 consumed to 72, C4 was normal range, rheumatoid factor positive 22, ANA and anti-double strand DNA negative, 24-hour urinary protein 5 gram, and albumin 3.2. Ultrasound was liver cirrhosis, surgically removed spleen, mild ascites, normal site and side of the kidney with increased echogenicity. At the management, patient received 2-session hemodialysis and renal biopsy was taken. The hallmark of the tubular interstitium show infiltration, massive infiltration of small and medium-sized lymphocytes. The patent glomeruli show thickening of the glomerular basement membrane. Immune can deposits of C3 along the glomerular basement membrane and the positivity of CD20 and CD3. At the conclusion, renal biopsy picture could be an infiltration from a lymphoma or primary lymphoma in the kidney. Non-contrast CT scan of the neck, chest, abdomen, and pelvis showed multiple enlarged lower cervical lymph node, largest 2 centimeter, mildly enlarged retrocaval lymph nodes 1.5 centimeter, multiple enlarged peripancreatic, porta hepatis, para-aortic, and aortocaval lymph nodes, largest 2 centimeter. PT scan, multiple bilateral variable-sized upper and lower deep cervical lymph nodes, more evident on the left side, measuring up to 2.3 centimeter, multiple bilateral variable-sized axillary lymph node, more evident on the right side, measuring up to 1.7 centimeter, multiple mediastinal lymph nodes at paratracheal, aortopulmonary, and retrocaval, measuring up to 1.5 centimeter. At the follow-up, patient became dialysis dependent and referred to oncology for lymph node biopsy. Lymph node biopsy was taken and showed non-Hodgkin's lymphoma, small p cell type. Patient received chemotherapy for lymphoma, but unfortunately he passed away later on. We have multiple questions about our case. Our patient was HCV positive, cured or occult. Can hepatitis C go away on its own? The answer is yes. From 50 to 20% of the people can clear from hepatitis C without treatment. What is the definition of Occltc? As definite as the presence of HCV RNA in hepatocytes and peripheral blood mononuclear cells without no detection of HCV RNA in the serum. Can we differentiate between occult or cured? Yes, by liver biopsy. This is an invasive method. Liver biopsy remains as a gold standard for diagnosis of Occltc. What is the relation between HCV and lymphoma? جاكوب إيتال في 2021 كان بيتكلم على الريليشن or extra hepatic manifestation of HCV. B cell non-Hodgkin lymphoma presented by 11%. HCV is not a hepatotrophic only virus, but also lymphotrophic virus. In the same year, another study بتتكلم على الepidemiology and lymphogenesis. How can virus C induce the lymphoma? 3 pathway for HCV to induce the lymphogenesis. By chronic antigenic stimulation lil B cell, by HCV antigens, or by high affinity of HCV to the receptors on the B cell surface, which is called the CD81, or by direct infection lil B cell by HCV. لطفي إيتال في 2020 اتكلم على percentage of HCV among lymphoproliferative disorders patient. Percentage was about 72. Half of them was Occltc infection, and another half was Over-TC. At the management. Actually, how can we manage a patient lymphoma induced by virus C? By antiviral only, by chemotherapy, or by a combination of them? بوزاتو إيتال في 2016 عمل meta analysis about to more than 100 people different type of lymphoma induced by HCV. All of patients received antiviral only. About to 60% of the patient حصل لهم complete remission. About to 30% حصل لهم partial remission. It's a debate area. So, to choose the best therapeutic strategy, several factors should be taken in consideration. Number 1, tumor burden. If the tumor burden is large, chemotherapy becomes the first choice. If low, antiviral therapy becomes first choice. The course of the disease. Lymphoma occasionally discovered during the follow-up of the patient of HCV, to antiviral the first choice. Or lymphoma progressive course and rapid node or spleen enlargement, chemotherapy become the first. The last one, the symptoms of the patient, tumor-related symptoms or virus-related symptoms. Our patient didn't receive the antiviral treatment. He excluded from the treatment. Why? The Egyptian protocol for the management HCV infection up to 2020 treated HCV according to the positivity of HCV RNA, not according to the titration. So, take-home messages at the end. It must be taken into consideration. Occltc infection may predispose to reactivation into clinically evident HCV, so it must be treated. Screening for Occltc infection should be considered in individuals at high risk for developing lymphoproliferative disorders. Liver biopsy remains the gold standard for the diagnosis of Occltc infections. Lymphoma regression was closely correlated with a decline in viral load under antiviral therapy. Post-remission HCV eradication after successful immune chemotherapy of non-Hodgkin lymphoma might be considered to prevent recurrence. Finally, treatment of HCV non-Hodgkin lymphoma should be performed in a specific approach with hepatologist and hematologist. Thank you.